Hello, everyone. Welcome and thank you for joining us today. My name is Rohit Mehra. I am chair of the GUPS Education Committee, and I'm honored to open this virtual education series event session organized by our GUPS Education Committee. Like everyone may know here, GUPS has been founded with a clear mission to enhance patient care through excellence in education, research, and implementation of best practices. We are here to learn and share in the collective progress we are making towards advancement in the field of urologic pathology. Today's session is actually the second part of this series and specifically focuses on a critical and evolving topic and is entitled Tumor Staging Parameters and Associated Challenges in the GU Pathology Domain. In the previous session, we focused on penile, renal, and testicular tumors. And today we will be covering the prostatic and urothelial events. And then we have a premium clinician who's a urologic oncologist who will be guiding us about the clinical aspect of the story. We are indeed privileged to have three outstanding genitourinary colleagues speak at today's event, Dr. Bonnie Choy, Dr. Paari Murugan, and Dr. Udit Singhal. The session is being moderated by Dr. Jeff Chen from Memorial Sloan Kettering Cancer Center and by Dr. Emily Chen from Stanford University, who are both members of our GUPS Education Committee. We encourage you to submit your questions within the Zoom Q&A tab throughout the session. Our speakers will address them at the end of the three presentations. Without further ado, I'm requesting Jeff to introduce our first speaker, please, Dr. Bonnie Choy. Over to you, Jeff.
Thank you, Rohit. So our first speaker today is Dr. Bonnie Choy. She is an associate professor of pathology at Northwestern University Feinberg School of Medicine and associate program director of the Cytopathology Fellowship. She completed residency and fellowship training in anatomic and clinical pathology and geopathology at University of Chicago, followed by a cytopathology fellowship at Mass General Hospital. Her clinical and academic interests include geopathology and cytopathology. Her research focuses on bladder cancer, investigating immune features of response to immunotherapy and tumor heterogeneity, as well as kidney neoplasms, examining morphologic and ancillary techniques for diagnostic evaluation. She is actively involved in regional, national, and international pathology organizations, currently serving as president of the Chicago Pathology Society and in leadership roles within the Illinois Society of Pathologists, the American Society of Cytopathology, and the College of American Pathologists. Dr. Choy will be speaking on the topic, updates on urothelial cancer pathologic staging and associated challenges. Bonnie, please.
Thank you so much for the kind introduction, Dr. Chen. Let me just get to the right slide for you. Perfect. Everyone can see my screen? Okay. Well, thank you again for everyone to be here today with me to talk about an area within GU pathology that I'm really excited about and interested about. And thank you for the organizers, moderators, for the opportunity to be here and suggesting such wonderful topic to talk about. So with the time that we have, I want to make sure that we're hitting some of the highlights, but certainly not be able to go through very comprehensively on every single part of pathologic staging within the urinary tract. But with that said, I have nothing to disclose, and here are some of the areas that I would love to dive into a little bit more with you today. And hopefully we have a better idea of how to approach some of these challenges with what we have that we understand within the literature in these areas. So first, let's tackle topographical variations of bladder. And along with anywhere in the urinary tract, with the tumor, we first have to decide whether or not it is invasive or a non-invasive tumor. And then based on the depth of invasion and how extensive the tumor is invading, we are basing our stage. with the extension of the tumor itself. So starting from even the macroscopic examination, there's a lot of details and a lot of information that we can glean from that. And then we put the pieces together in which sections do we submit, and then how do we evaluate under the microscope. So a lot of the topics that we'll touch upon today really incorporates all the way from the grossing to the very end, when we finally are able to decide on the stage for our tumors that we're working with. So, when we think about just an illustration of the urinary tract, it might be somewhat understandably comprehensive, meaning like, okay, if it is invading into the lamina propria, it is the stage, if it's muscularis propria, etc. This seems simple enough. However, there are some variations depending on where the tumor is within the bladder. And I want to highlight some of those changes in one of the publications that really go into detail into the various differences that is within the bladder itself. And of course, when we're looking at the bladder, we're kind of talking about different parts, starting with the trigone. We have anterior, posterior, the two lateral walls, and then the dome. And if we're just focusing on the lamina propria itself, there is actually a difference in the depth and thickness of how the lamina propria is depending on the location. The most drastic difference here you can see is that in the trigone, it's very thin comparatively to the dome, where it is almost double the thickness that you find on average compared to the trigone. So within the lamina propria itself, there's already a drastic difference depending on where the tumor is and what kind of specimens you might get. And within the lamina propria, we're talking about muscularis mucosa, the muscle layer that is lying within the middle of the lamina propria. So it's a busy table. However, there's a lot of information that's really great about this. Here, I just really want to point out first the vascular plexus that is within the lamina propria. That we will talk about a little later as another landmark that we can use to distinguish where the muscularis mucosa is for staging purposes. And you can see it's seen in every single part of the bladder. However, when we go into more details into exactly where those vessels lie, some are at the level of the muscularis mucosa. However, you can also see the plexus vessels being potentially a little above, a little below, or throughout the lamina propria. So that presents a potential challenge if you're trying to use the vascular plexus to determine where the muscularis mucosa is. But to jump further down into some of the variations, and again, I think the trigone and the dome are the two sites that are very drastically different compared to all the others. With the muscularis mucosa, we learn how the characteristic look of these muscle bundles is wispy and thin within the lamina propria. However, the paper did note that there are areas where they have hyperplastic muscularis mucosa, and they define hyperplastic muscular bundles being 4 muscle fibers in thickness or greater. And there's a drastic difference between the trigone and the dome, where in the trigone, you most often see kind of this absent or at most wispy thin muscularis mucosa, while in the dome, you're seeing more of that hyperplastic muscle bundles, which may or may not look more like muscularis propria compared to muscularis mucosa. And similarly, the distribution of it, much less of the muscularis mucosa is seen in the trigone, much more of that discernible layer of muscularis mucosa in the dome. And additionally, the muscularis propria in the trigone, the authors of this paper have recognized that as the bundles of muscularis propria approaches to the surface, to the suburothelial layer, the bundles get smaller and gets more irregular, and it tends to almost look like muscularis mucosae, even though it is a muscularis propria. So some of these variations, again, very different between most drastically dome versus the trigone. In the dome, the hyperplastic muscularis mucosa, it can be seen in a deep lamina propria, and it also has this compact arrangements, making it look like muscularis propria. Keep that in mind, since these could potentially be mistaken and it might impact staging. So with then the trigone, we know that the lamina propria is very thin in the trigone area. Oftentimes, there's absent or rarely present muscularis mucosae in the trigone, and there's also that change, the decrease in the muscular bundles as you get closer to the surface, where it could potentially be questioned whether or not are we seeing muscularis mucosae versus muscularis propria in those areas. So kind of some of the things initially to keep in mind, and some of these things come into play as we talk more about different parts of the urothelium and some of the challenges that we have to face in staging. So let's talk a little bit more about urothelial carcinoma in the diverticulum itself. So bladder diverticula, we know that most are acquired in adults, if we're focusing on the adult population, and it lacks muscularis propria layer. So frequently, also, we do see, again, this hyperplastic muscularis mucosae in the bladder diverticula. So one of the challenges, again, is, are we mistaking hyperplastic muscularis mucosae with muscularis propria? And so knowing that this tends to be seen more frequently in the diverticula can help you avoid that pitfall, because most of the time, the bladder diverticula really lacks that muscularis propria. And just a little bit more about characteristics of diverticula itself in the bladder. It can be very small, or it can, in the study, pretty large in size. And I think one of the things that, if we pause and have talk about this and talk about the practicality of how to approach a potential diverticulectomy specimen, there's times when I think there's a little pearl from just experience of seeing these. We get the specimen from the operating room. It's labeled bladder rather than potentially diverticulum from the surgical team. And I think one of the things to really do have anyone who's grossing to keep in mind is, really dive into just a little bit more about why the patient is having the surgery, exactly what is going on, what kind of surgical procedure are they actually performing? Because there has been times when a diverticulectomy, a diverticulum was resected, and sometimes it's shaped rather similarly to a bladder because of just the way that the diverticular is, but it was labeled as bladder, and the person who was trying to orient the specimen didn't realize it was an actual just a diverticulum instead of the whole bladder, and struggled with trying to orient the specimen like a bladder, but certainly finding very difficult time to do so because it's only a diverticulum. So really try to spend a little bit more time on understanding exactly where that the tumor is, exactly what kind of specimen it is, before approaching it. That might save you some time and frustrations when you're approaching these specimens. So with that said, with the diverticulum, a lot of the times it can happen anywhere in the bladder, but most often it's kind of on the lateral walls and the posterior wall where we see diverticulum. And when cancer, urothelial carcinoma, is involving the diverticulum, in the 8th edition of the AJCC, we have finally kind of recognized the approach of not staging any and skipping PT2 stage because there is no muscularis propria layer within the diverticulum. In the image on the left, you can see that is a portion of the diverticulum where we have, if the tumor goes into PT1, yes, we can stage that into that subepithelial connective tissue. There is no muscularia propria, so we're skipping PT2. And if the tumor kind of goes into past into the extravascular tissue, then it's PT3. So we go from PT1 to PT3 and we skip PT2 in the staging of urothelial cancer in the diverticulum. So with that said, we do wonder if we don't have muscularis propria, understandably, we think, is that one last layer where the tumor have to go to extend past the diverticulum into the extravascular fat. And would that potentially mean a poor outcome for tumors that can extend more easily into the extravascular fat? What does that mean? Would that be poor outcome for those patients who have urothelial carcinoma in the diverticulum? Right now, from what the limited data that there is out there, it seems to just suggest that there are comparable outcomes comparatively to non-diverticular tumors. So they don't necessarily have a worse outcome because the tumor is in the diverticulum. One of these limited data studies that we have on this topic is this one by Hu and the team. So they looked into urothelial carcinoma that were in the bladder diverticulum and then compared it to another subset of urothelial carcinoma that was just in the bladder and not in the bladder diverticulum. And when you look at those that are in organ confined or recurrence-free survival and overall survival, there's really no significant difference between the two. Same with the specimens that were extravascular, so PT3 specimens, whether or not they're in the bladder diverticulum or not. Again, neither recurrence-free survival or overall survival makes any difference between the two. So it seems like it doesn't really impact outcome, and patients with cancer in the diverticulum doesn't necessarily mean that there is a poor outcome for them. Moving on to prosthetic stromal invasion, here's another challenge. Before we think about prosthetic stroma before the 8th edition of the AJCC, we're thinking about PT4 being the staging that we use. But then when we move into the 8th edition, we really do at that point recognize that there's really two pathways that really changes the staging and how the patients perform based on which route the cancer takes. So there's two routes. One is if the bladder carcinoma extends down towards the prostate by the route of the prostatic urethra and then invade into the prostatic stroma. That's one route. But then there's also the transmural route, which is a separate route of where the bladder cancer goes through the bladder wall and then invading into the prostate, invading into the prostatic stroma. Or it goes through the bladder wall into perivesicular soft tissue or fat, and then go into the prostate, saying still transmural, but then two different paths. And studies have shown that urothelial carcinoma with the intraurethral prostatic stroma invasion has better outcome, better nice recurrence-free survival, overall survival than those that have the transmural prostatic stromal invasion. And there's a lot of good material, good data out there that really supports these two paths. And so with the 8th edition of the AJCC, we do have the two approaches. If the tumor extends down through the prostatic urethra and goes into the prostatic stroma, whether it's the prostatic urethral urothelium and then directly go into the prostatic stroma. That's one route. The other is extensively kind of involving into the prostatic acinar and ducts. And then from that point on into the prostatic stroma, still PT2, use the urethral staging for that type of tumor. And then separately, if the tumor is invading through the bladder wall into the prostate or outside of the bladder through the bladder wall and then back into the prostate, that's a PT4A, another separate route. And so a lot of this really matters. We saw a lot of data that really supports this move of having the two different staging for the route that the cancer takes. And there's additional validation of the different staging where the intra-urethral prostatic stromal invasion. So now that PT2 using the urethral staging compared to the PT4 really did show lower rates of lymph node involvement and positive surgical margin and better overall survival and cancer-specific survival. So this is definitely something that is important to really note and document how the tumor is involving the prostate stroma. And that, again, goes back to macroscopic approaches of, really examining, really taking sections at the time of grossing that shows the path of where the cancer is going and how it's involving the prostate itself. And so when the route is transmural through the bladder wall, again, PT4A per the urinary bladder staging, if the path is an intraurethral spread and then involves the prostatic stroma, then we use the urethral cancer staging for PT2. And then what about, urothelial carcinoma that involves the prostate, but then there's also a concurrent bladder cancer. In that instance, we separate urinary bladder and the prostatic urethral staging for each of the sites. And why do we not lump it all together and just pick the higher group, higher stage, etc.? There's some literature out there suggesting, for one example, 5-year cancer specific survival when we have PT2, so PT2 prostatic stromal invasion, with a concurrent muscle invasive bladder tumor. Compare that to, again, a PT2 with no concurrent muscle invasive bladder tumor. There is a significant difference between the cancer specific survival. So stage both under those circumstances, and there is potential difference in outcome because of that. So there's a lot of times where you get very complicated, interesting specimens like this, and we call one particular one where I have a very large, aggressive small cell carcinoma tumor in the bladder, anterior wall of the bladder, that was separate from the other more conventional urothelial carcinoma that was involving the prostatic stroma in that intraurethral spread route. And so, sometimes when we put out the report saying that it's prostatic stroma, everyone, immediately thinks PT4. So, when these occasions where there's potential separate tumors and prostatic stroma is involved, I would just emphasize that trying to really make a thorough comment, a very descriptive comment in how the route is and why you arrive to that PT2 staging for the prostatic stromal involvement rather than a PT4 is very important, and it does make a difference. So communication, it's spend a little bit more time on just teasing out the details to make it clear to whoever's reading the report how the bladder cancer is involving each site. So, again, talking about a little bit more about grossing, very important in a component in how we stage our tumors. I will argue for any sites within the urothelial, within the GU area, but definitely in the urothelial tract. So here is a more recent study where they compare kind of a more minimal sampling of the prostate when we get a cystic prostatectomy specimen for bladder cancer. So in group 1, they are just having a minimally sampled prostate, depending on which institution you're at. You know, we sometimes get one section on the right, one section on the left prostate, maybe a few sections at most, but more often than not, we're not submitting the whole prostate in these types of specimens. And so they compare that in group 1, where there's minimal sampling of the prostate in these specimens, to a more comprehensive submitting the whole entire prostate in group 2. And when they compare group 1 minimally submitted prostate to group 2, where it's completely embedded, much more thorough, the results shows that in the group 2, where the whole prostate was submitted, they were more likely to find and identify prostatic ducts and SNI involvement by CIS compared to group 1, and that was significantly there was a significant difference between the two groups. And group 2 also were more likely to have prostatic stromal invasion compared to group 1, but that was not a significant difference between the two. So one will argue if we submit a little bit more of the sections, we might potentially impact and find findings where it might impact the staging of our tumors. So I think, you know, for us, practical approaches of how do we work up and determine the final staging in some of these specimens involving the prostatic acini and ducts, whether or not there's stromal invasions could be a very big challenge. There's definitely been time where we get a specimen where we have urothelial carcinoma involving the prostatic urethra, very extensive CIS, and every single section, and we submit the whole prostate, every single section has just extensive CIS diving into prostatic ducts, prostatic acini, and you're trying to find, is there stromal invasion that would bump it to the next stage and makes a difference. So sometimes we do wonder, is there some good IHC that we can use out there? There are some literature that shows, you know, in this study, for example, a dual stain with high molecular weight keratin and GATA, GATA in brown, high molecular weight keratin in red. And in this, they're showing a carcinoma in situ tumor that's involving the prostatic duct, really nicely highlighting the basal cells with the high molecular weight keratin and the GATA inside those prostatic acini. And then another comparison of where now we have prostatic stromal invasion from the urothelial carcinoma, because there's no red highlighting, no high molecular weight keratin highlighting the basal cells in those areas, and we can compare that with the benign prostate gland that is sitting on that bottom left corner there. So potential usage of the high molecular weight keratin versus GATA, and in this study, when they were using the stain in 7 difficult prostatic stromal invasion cases, 2 of those with the stain, they were able to prove that there's prostatic stromal invasion. 5 cases, they found CIS. So maybe some utility there. And other study kind of suggested using D240 and compare that with CK56 versus high molecular weight cytokeratin. Here is an image of the D240 cytoplasmic brown staining that's highlighting the basal cells in a prostatic duct, and then the urothelial carcinoma that is spreading into the duct partially, and that is completely negative and more zoomed in magnification of the D240 stains, again highlighting, nicely the basal cells, and in the studies, they found that D240 was negative for urothelial carcinoma, benign urothelium, prostatadenal, the benign luminal prostate epithelium. Comparatively, it seems to be much cleaner in highlighting the basal cells compared to a CK56, which at different tumors, there's patchy staining on the tumor periphery, and also a high molecular weight keratin, diffuse staining kind of in the intraductal and invasive urothelial carcinoma. So they're suggesting that D240 might be a really potential useful stain in those times when you want to determine whether or not there's stromal invasion in the prostate. Renal parenchymal invasion, I'm seeing the time and I'm going to try to move fast. So there's different staging, again, based on invasion and where is invading. So to note though, in the major calyxes within the renal pelvis, the musculature is not really well developed. So a lot of times we're staging either PT1 or jump all the way to PT3. And on the rarest occasion where you do see muscularis, you can stage a tumor into a PT2. And then in the minor calyxes, the urothelium actually lies directly on the renal parenchyma. And so when the tumor invades, it really kind of jumps all the way to PT3 in those areas. And one of the things about renal parenchymal invasion are all PT3 the same. We're really lumping a large group of specimens, tumors together, whether or not it's invasion into the renal parenchyma, the medulla or the cortex, invasion into the fat, or both. And we've seen kind of a difference in survival among those patients. And here's a really great gross gross picture. Again, beautiful picture. And it's just so nice when you have the macroscopic examination helping staging purposes. This is from one of the papers we'll talk about next. But there's renal medulla invasion. You can clearly see that. And then on the right, you see medulla, but also the cortex and the peripelvic fat being involved by the tumor. In one of the studies, trying to subclassify PT3 into PT3A, which is just the renal medulla invasion, and then PT3B, the cortex, the solid kind of lime green and the orange. You can see that there is a difference when you split the two groups into substaging. And then
sorry, you have 1 more minute, please.
Okay, sure. And so again, there's different ways of kind of grouping together the staging. And so there's a lot to be said about potentially an area that we want to talk about. Intratubular spread, there might be some differences there too. And I just want to really jump quickly into PT1 substaging issues. There's a lot of differences there. Histoanatomical substaging, we use the muscularis mucosae as the target, but there's a lot of challenges into identifying the muscularis mucosae. So there's other options of micrometric substaging. The amount of tumor is at 0.5 millimeter. There's a difference between the two. Other system using potentially a greater diameter of 1 millimeter, showing differences. Or you can also measure the total linear extent and variations of this. And so with PT1 staging, there's a lot of meta-analysis showing the differences between does it predict recurrence or disease progression, between limitations of whether or not you're measuring using histoanatomic system, micrometric system, etc. And I will end with this of in block and resection. There's a lot of discussion out there of potentially, hey, if we get a better specimen, an intact specimen where we can orient better, and we potentially be able to assess the invasion. However, this is kind of out of our hands. But if we do get a better oriented specimen, we potentially be able to use any of the PT staging more applicably. And so here are some of the differences between the two using that system. So with the amount of time that we have with PT1 substaging, it is encouraged, but we really don't have a consensus or recommendation as to which substaging system that we have. There's a lot to talk about, and I wish we have more time, and certainly I would love to be able to, answer any questions later. And again, thanks for everyone's time, and thanks for the organizers and moderators for this opportunity.
Thank you so much, Bonnie. It was really great. Wish you had more time too. But I really enjoyed every part that you touched on. So we're gonna move on to our next speaker, who is Dr. Paari Murugan. And I'm really excited to introduce him. He's a professor and director of surgical pathology at the University of Minnesota Medical Center, where he also serves as the expert consultant in GU and bone and soft tissue. In addition to his clinical diagnostic role, for which he has received several clinical excellence and top doctor awards, he's also deeply committed to education. He was honored with the Anatomic Pathology Teacher of the Year Award in 2015, 2018, and 2021. He has published over 110 peer-reviewed articles and has served as a co-investigator on multiple NIH grant-funded projects. His professional leadership includes elected memberships on the CAP Cancer Committee and the AJCC Retroperitoneal Sarcoma Panel. He also serves as an expert reviewer for the NCI's Cancer Path Chart Initiative, and he directs the UMN Surgical Pathology Fellowship Program, and he is the section editor of Urological Pathology for the journal Diagnostic Pathology. So Dr. Murugan will be speaking on the topic, updates on prostate cancer pathologic staging and associated challenges. And so I'll turn it over to Paari.
Thank you, Dr. Chen. Appreciate the introduction. Share my screen now. Hopefully everyone can hear me well.
Yeah.
Do you see my screen?
We see it in the PowerPoint view.
Yes.
And then, yep. So, perfect.
All right. So, thank you. So this is the University of Minnesota campus, and that's our hospital located on the banks of the beautiful Mississippi River. So I would like to share with you some updates on prostate cancer pathologic staging and the associated challenges that we come across in day-to-day practice. So if you look at the pathologic stage overview, most of us are familiar with how this is done for prostate cancer. And we start with PT2, and we don't use PT1 as part of pathologic staging because PT1 is completely clinical staging, wherein the clinicians, wherein the prostate cancer is not palpable, and the clinicians find cancer in a TURP specimen. If it's less than 5%, it's going to be PT1A. If it's going to be more than 5%, PT1B, and in a patient with increased PSA, if the cancer is found on the biopsy, it's going to be PT1C. Where pathology comes into the picture in terms of staging is when we have a prostatectomy specimen, and then we look at it and find that the cancer is entirely organ confined. So that's going to be PT2. And typically, as we see in this image, prostate cancer is a multifocal cancer. Occasionally, you may have a dominant nodule, but PT2 will be entirely confined to the organ. Earlier, we used to subclassify PT2 by the laterality and extent, but the AJCC staging no longer recommends that, and it's not prognostically useful. We'll look at that in a minute. So, and then the next stage would be PT3, where you have two subdivisions. That is PT3A, when the prostate cancer extends into the extraprostatic fat, or at the base of the prostate, it extends into the bladder neck muscle, microscopic invasion into the bladder neck muscle. The word microscopic here is critical. And then PT3B is when the prostate cancer extends into the muscular wall of the extraprostatic seminal vesicle. So again, the word extraprostatic is critical here. And then PT4 is when the cancer is no longer organ confined. It extends not only out of the prostate, but also involves adjacent structures. And the structures in the vicinity of the prostate can be involved in PT4 disease, are going to be the rectum, rectal wall, or the pelvic wall, or down below you have the urogenital diaphragm or the pelvic floor musculature. And then up above you have the bladder, and macroscopic involvement of the bladder wall will again constitute a PT4 disease when the cancer is fixed to the adjacent structures. In terms of end staging, PN staging is rather straightforward. PN disease is a designation given when the prostate cancer involves one or more regional lymph nodes, that is lymph nodes in the pelvis. So there is some controversy as to whether PT end stage should be subdivided or there should be a PTN2 perhaps when you have more than one node involved. But as of now, prostate cancer, unlike bladder cancer, has only one PN stage, irrespective of the number of nodes that are involved in the true pelvis. So if the non-regional lymph nodes, if the non-pelvic lymph nodes are involved, then the prostate cancer is upstaged to PM1A. And if you have bone involvement from the cancer, it's going to be PM1B, and visceral involvement, which constitute a PM1C disease. So in terms of staging updates, not much has happened since 2018 when the latest edition of the AJCC staging manual as far as prostate cancer is concerned was published. There were some changes compared to the previous edition of the AJCC staging manual, which is 7th edition in 2011. And the important change, as I mentioned previously, was the removal of the sub-staging of PT2. Because the PT2 basically was top-staged earlier as PT2A disease involving one lobe of the prostate, less than half of its volume, and PT2B involving one lobe of the prostate, more than half of the volume of the lobe, and C being bilateral involvement of the prostate lobes. So it basically was removed because there was no prognostic significance between the subdivisions of A, B, and C. And the problem was that the other problem that needs to be considered is the fact that for a potentially PT2C disease, you could have two tiny nodules, two perhaps 0.5 millimeter nodules distributed, one on each lobe. And you could have another case where you have a really large voluminous nodule occupying only one lobe of the gland. So the latter would be categorized as PT2B, even though it probably has a worse prognosis compared to two tiny nodules in either lobe, which would be categorized as PT2C. So because of this, the substaging of PT2 as far as pathology is concerned was removed. And then the other update, as we all are well aware of, is that the grade groups were introduced after the 2011 edition was published, and this is now included as part of the staging of prostate cancer, the stage grouping of prostate cancer. Again, as we all know, the grade groups are a simplified system that condenses the Gleason score into these 5 categories. And it's easier for patients to understand because you now have grade group 1 of 5 being the lowest score instead of a confusing Gleason score 6 of 10 being the lowest score. And then the other key thing that this categorization achieved was the Gleason score 7 was rightfully separated into 2 prognostically distinct categories as grade group 2 and grade group 3. And overall, the grade grouping system has a superior prognostic value and strong correlation with biochemical recurrence. So the justification was there for including this as part of the stage grouping. And then the last change that happened, or the last update that happened, was that in the prognostic stage group, stage 3 included select organ-confined disease. So this is unique to prostate cancer. No other cancer in the human body has stage 3, which basically means the cancer has extended outside of the organ to include organ-confined disease. So if we look at the stage grouping of prostate cancer, again, it's unique and it's a select group of cancers where we use non-anatomical factors for stage grouping the tumor. So typically, most cancers use just the TNM system, wherein you're looking at the tumor size, the depth of invasion, and the extent of spread. In addition, prostate cancer stage grouping also includes 2 key parameters, which is the PSA and the grade group. So in terms of the change that I was just mentioning, stage 3A now includes tumors that are organ confined, either T1 or T2, but have a PSA value of greater than or equal to 20. So this basically stage is upgraded based on the PSA, despite the cancer being organ confined. And other important point to note in this stage grouping is that despite irrespective of the T stage or N stage or the M stage, if a patient is diagnosed with grade group 5 on a prostatectomy specimen, that alone indicates upstaging to stage group 3C. So these are some key points to note in terms of stage grouping of prostate cancer. Now I just want to talk about more of pathology issues and what the challenges and controversies are in pathologic staging of prostate cancer. So I want to start with a grossing approach because it all starts with grossing, and we'll quickly take a look at the pros and cons of various techniques before moving on to discuss the histopathologic features of the staging prostate cancer. So prostate cancer, as you all know, basically when we grow them, we cut them into parallel slices in a transverse manner, and then the apex is perpendicularly sectioned, and so is the base, and the base of the seminal vesicle is submitted with the option of submitting more seminal vesicle tissue. So once this is done, now there are several options to consider. One is submitting the entire gland as whole mount sections, or submitting the entire gland as quadrants from each of the slices, or partially embedding these slices in quadrants. So the other thing I want to talk about is the advantages or the pros and cons of whole mount versus conventional submission of prostate cancer or prostatectomy specimen. The whole mount preserves the architectural orientation. It's useful for teaching. It has a really good representation of the spatial context for EPE, and it also really helps imaging-based correlation with MRI studies and imaging-based AI studies compared to quadranted sections. And also with whole mount, you can submit a fewer sections, and thereby you can potentially examine greater amount of tissue. These are the advantages. However, it does need dedicated infrastructure because you need specialized microtomes and you need specialized storage cabinets for the larger tissue cassettes and the tissue blocks, as well as the larger tissue slides. And it also needs considerable experience from the part of the microtomist to prepare these sections. And in addition, it has been shown in several studies that it's not superior in detecting the key adverse pathologic features compared to quadranted sections that are used in most laboratories. So both methods are acceptable. In terms of partial versus complete embedding, the recommendation is if you see grossly visible cancer, like in the specimen over here, you can get away with partial submission of the slice involving this cancer or a couple of slides above and below it, along with the tumor and the periprostatic tissue. But the problem is sometimes grossly visible cancer may not be that obvious. In this case, we have some some nodules over here, it's easy to determine that this is actually BPH because of the location. So these nodules do look fleshy and tan, somewhat different from the cancer, but sometimes cancer can have the same appearance. The fleshy tan appearance of BPH can be replicated in cancer. So in these cases, it might be difficult to assess the gross tumor. And then in other cases, you may have similar looking nodules that you're not sure whether it's cancer or BPH located in the TZ compared to nodules in the peripheral zone that are clearly cancer. So it can be somewhat problematic to determine grossly visible cancer. So if you don't have grossly visible tumor, as in this example, you can either do total submission of the prostate or in any approved way of systematic partial sampling. So there are several methods of systematic partial sampling. The most commonly used method is to submit every alternate section. And then another commonly used method is when you submit all the posterior sections and a couple of sections from the mid-anterior zone, so that you can detect some cancers that either arise in the TZ and spread to the anterior zone, or arise in the ends of the peripheral zone and percolate into the anterior zone. So you'd be covering those cancers as well. And of course, if irrespective of the method of submission, all submissions should include standard sections, which is basically the perpendicular section apex, the base, and the base of the seminal vesicles. So what is the advantage of complete embedding over partial embedding? Is there any advantage? So complete sampling provides new information in not too many cases, in only 2.1% of cases. So in a fairly exhaustive study done by Collette et al., they showed in 564 cases of prostatectomy where they used the same case and studied first partial sampling by only looking at these alternate sections and then complete sampling. They were able to show that upstaging of key parameters, that is PT2 to PT3, happened only in roughly 1% of cases. And even in those 1% of cases, the change was only focal EPE. And then in another 1% of cases, another critical parameter that changed was negative to positive margins. But then again, these margins were restricted to 1 to 3 millimeters of involvement. So partial sampling or partial embedding is an approved method, and we don't necessarily need to do complete embedding. Now, I want to move on to the key things I'd like to talk about today, which is basically the staging challenges. So I want to discuss extraprostatic extension and bladder neck invasion, seminal vesicle invasion, and if time permits, lastly, how to properly grade a dominant nodule. So in terms of extraprostatic extension, it's pretty clear that it's a significant predictor of recurrence in node-negative cases. It can be challenging, though, since the prostate does not have a discrete fibrous capsule. It does have an ill-defined band of fibromuscular tissue that's inseparable from the prostatic stroma in the posterior aspects, lateral aspects, and posterolateral aspects. But this ill-defined band, which roughly separates the extraprostatic tissue from the prostatic parenchyma, cannot be readily identified due to the anatomy in the anterior region, the base region, and the apex regions of the prostate. So I want to take a closer look at these areas. So in the posterior and lateral prostate, so the definition of extraprostatic extension is essentially neoplastic glands that either abut the periprostatic fat, like in this case, where you see this tumor nodule that's beyond the plane of the fat, is not intermixing, but abutting the periprostatic fat, that would be EPE, or in a case that is clear-cut like this, when you see the tumor intermixed with the periprostatic fat, that would be EPE2. So these are two fairly straightforward examples. The other thing that you could do, or the other part of the definition, if you do not see fat, then you need to determine that the tumor is in the loose connective tissue outside the fat plane. So in this case, if you draw, that's the fat plane, and if you follow the contours of the prostate, you can see that this area is in the connective tissue with some desmoplastic reaction outside the fat plane. So that would be EPE, or if that's not possible to do, the other thing that can be used is to notice that the prostatic cancer is beyond the compressed fibromuscular stroma. So this is a compressed fibromuscular stroma that belongs to the prostate, and then outside of it, you can see that it becomes this loose connective tissue. So in this particular region, if you look closely, you will see that the compressed fibromuscular stroma kind of stops over here, and this part would be the extraprostatic tissue. This would be EPE involving a perineural space. However, it's not going to be straightforward in all cases. Then you do have a straightforward example. This is how it would look like. You have the compressed fibromuscular stroma of the prostate, which is pink and with the thicker muscle bands compared to the extraprostatic tissue. Even though it doesn't have too much fat, it does have this loose fibroconnective stroma and can be clearly distinguished from the prostatic stroma. However, what happens is that it's not a consistent finding. In some cases, you can find this compressed prostate type looking stroma that's actually beyond the fatty tissue. And this would be considered as extraprostatic plane if it crosses a fatty tissue. So that becomes an issue. And then in some cases, you can see the loose fibroconnective tissue stroma actually having benign glands. So it becomes a challenging and somewhat of a subjective assessment, and one has to use their judgment. Another scenario that one might come across is like this: when you're trying to define the plane that's beyond the fat component. So in this particular example, you don't see a clear distinction between the compressed prostatic stroma and the extraprostatic tissue, but I do notice a cluster of fat cells over here and a cluster of fat cells over here, and the cancer is over there. So subjectively, one pathologist could interpret this as beyond the plane of the fat, whereas another pathologist could determine this as just the normal contour or the bulging of the prostatic parenchyma and interpret this as still being within the prostatic parenchyma. So it is a subjective exercise, and no wonder the kappa value for determining extraprostatic extension is poor. It's about 0.33. So it is a challenging area. Another thing that I want to mention over here is if you look at this section very carefully, right at the edge of this tissue, right about over here in the extraprostatic fat, you can see this tiny little gland. So that tiny little gland is all by itself, and when you look closer, you will see it's associated with some hemosiderin pigmentation. So this is needle biopsy tract extension. Another case where you have high-grade, high-volume prostate cancer that seems to be confined to the prostatic stroma. Here's the extraprostatic tissue, and you have some tissue that looks unusual over here, maybe some fibrosis. If you look closer at this area, you will see actually there is a traumatic uroma that's formed over here along with fibrosis, and then a couple of glands lying in this fibrotic tissue. And these two glands are indeed prostate cancer with some immune infiltrate that's almost like wiped out the cancer in this area. In addition, we can see a foreign body giant cell reaction and some old hemosiderin pigmentation. So this is another example of artifactual needle tract displacement. This is a phenomenon that is not very common. But I would argue that this is something that somebody has to be very careful to pick up. Maybe that's why it's as rare as it's been documented. And it has been shown that when you do see it, usually these patients have bulky local disease, and it is more common when the biopsies are done in a transperineal fashion, but you can also see it in cases where transrectal biopsies are done. So as we saw during the last previous lecture, when you have on kidney cancer, when you have displaced cancer due to biopsies, this should not be upstage, and one should confirm that the biopsy site changes are present before diagnosing EPE. Now, the other issue that we want to talk about is what is focal versus non-focal EPE, how to diagnose it, and is it really significant? So this concept was first established by Dr. Epstein and colleagues in the mid-1990s when they said focal EPE is defined as no more than a few neoplastic glands in the extraprostatic tissue, perhaps something like this. And then Dr. Wheeler and colleagues further elaborated by saying that when you diagnose focal EPE, those glands in the extraprostatic tissue should involve less than one high power field in less than or equal to 2 sections. So this was shown along the years in the early 2000s that it did have quite a bit of prognostic significance. So this is a paper from the Johns Hopkins in, I think this was in 2015, which showed that focal EPE, patients with focal EPE has a much better biochemical recurrence-free survival compared to patients with non-focal EPE. However, there is a recent meta-analysis that came out in 2024, which compared high-quality papers that spoke about this subject and basically found out that there was no difference in the hazard ratio between focal EPE and established EPE. So it probably does not matter as much as we thought it did. And that also explains why it's not part of the AJCC staging system. And then the other thing that is important to speak about is the anterior evaluating extraprostatic extension in the specialized anterior fibromuscular stroma of the prostate. And the key player here is the skeletal muscle. So if you look at the anatomy of the prostate, in the anterior portion of the prostate, you basically have the bladder neck musculature that dips down along the surface of the prostate and comes to almost the lowermost or distal aspect of the prostate. And from the bottom, you have the levator ani, or the pelvic floor muscle, the skeletal muscle, which envelopes the prostatic apex and then goes upwards. And sometimes you can even find it in the mid to higher, more proximal aspects of the prostate, interlacing with the bladder neck smooth muscle as well as the fibrous tissue. So that forms the anterior fibromuscular stroma, and you can see it in the MRI as well. So that's the prostate gland, and this dark shadow is basically the anterior fibromuscular stroma. So in an actual specimen, you can trace it when you cut open the anterior part of the prostate. So that's the bladder neck musculature. It drops down like that towards the mid-anterior portion of the prostate, and the bottom you will have the levator ani skeletal muscles. When you look at the actual section, so this is the apical region, and in the apical region you have the striated muscle of the, so this would be the striated sphincter, which is contiguous with the levator ani, or the external skeletal muscle sphincter, and the peripheral zone stops right there. So this whole area would be the anterior fibromuscular zone, which you can appreciate in a whole mount section as well. And this is a mid-prostate where the anterior fibromuscular stroma continues. On the outside, you could see the bladder neck musculature coming up, and the peripheral zone starts to involve this area a little bit. And in the base of the prostate, the skeletal muscle is replaced by the smooth muscle, which actually forms the pre-prostatic sphincter, and you still have substantial anterior fibromuscular stroma in this area. So why do we need to know all this? So we need to know this because when prostate cancer involves the anterior fibromuscular stroma, it is very difficult to establish yea or nay for extraprostatic extension because this anatomy is ill-defined, unlike the posterior and lateral aspects where you at least have a sort of a pseudocapsule to help you. So you can see in this section from the apex of the prostate that the skeletal muscle basically percolates through into the extraprostatic area. It's actually so hard to determine what is extraprostatic here until you look closely and see there are some fat deposits in this region, and anything that would be beyond this fat would be extraprostatic. But in this area, you don't even have the fat, so you have to use the plane of the tissue to see whether the cancer is extending beyond this region. The skeletal muscle fibers do not help at all, and the key thing to understand here is that the skeletal muscle fibers are an integral part of the prostatic parenchyma in the anterior zone, and when cancer involves this area, it should not be called extraprostatic extension. Here's a section from the mid-prostate where you can see the bladder neck musculature down here interlacing with the skeletal muscle fibers and the smooth muscle fibers over here from the prostatic parenchyma. And you can also see normal prostatic glands in this stroma, which again means that this is the proper part of the prostatic parenchyma. So in a case like this, when the cancer involves the skeletal muscle in the anterior region, it should not be automatically called extraprostatic extension. And in fact, as I mentioned, you can see normal glands among the skeletal muscle in this area. And this is a case where we try to determine extraprostatic extension in the anterior prostate, and one cannot define the boundaries again, as I said, so one has to look carefully. If you look carefully, you will see that there are a couple of fat vacuoles here, and that would be extraprostatic extension in this area. As far as this area is concerned, you want to look at the fat. So here you have some fat clusters, and then probably some fat clusters in this region and this region. So you draw a rough plane connecting those, and anything beyond that would be considered extraprostatic extension. And in fact, you can see this in biopsies to this area. We have skeletal muscle and prostate cancer involving that, and they should not be called extraprostatic extension. Again, you can see normal glands as well within the skeletal muscle. So the other thing I want to talk about is bladder neck involvement, because this is very important. The key point to remember here, unlike in other organs, involvement of prostate cancer, the adjacent organ, i.e. bladder neck muscle, cannot be diagnosed as PT4 unless there is macroscopic tumor involvement. As you can see in this example, it should be either clinically diagnosed on the cystoscope or on the MRI or in a gross specimen like this. If you do not see this, it is only PT3A if it involves the bladder neck musculature. So how do we diagnose this? So microscopic cancer present within the thick smooth muscle bundles at the bladder neck would be bladder neck invasion. So these are the muscles that I was pointing out earlier. And these muscles are not only distributed in the periphery here. Once the resection happens, these muscles pull away, but you can also see some fragments stuck on the base of the prostate. So essentially the way we grow cystus, as you all know, you do a transverse section and do perpendicular sections of that and submit those. And this is a section that will come up. It's important to note that in this particular piece of tissue, even though it's submitted as bladder neck, the right half is essentially prostatic stroma, and only the left half, where you see the compact detrusor type muscles along with the fat in between, that's going to be the actual bladder neck. So when you do want to diagnose prostate cancer involving the bladder neck, you want to see the cancer that's actually involving this tissue and not adjacent to the thick smooth muscle bundles that are closer to the prostatic gland. So the definition, unfortunately, says absence of intermixed benign glands along with cancer present within the thick smooth muscle bundles in the bladder neck. So as you can see in this picture, there is substantial portion of the anterior fibromuscular stroma that's clearly part of the prostate that does not have benign glands. So even though there are no benign glands here and there are thick muscles, one cannot make a diagnosis of bladder neck invasion or extraprostatic extension in this area. So one has to be careful. So I would diagnose this as bladder neck invasion only if the cancer cross the fat boundary, which is basically starting from here up to this way, and not when the cancer involves this area, even though you don't have benign glands and you do have thick muscle bundles. Here's another example where clearly you can see the detrusor muscle interlacing with the anterior fibromuscular stroma at the base of the prostate. So it would be EPE or bladder neck invasion if it involves here and not here. So this is proper true bladder neck invasion when you see the cancer between the detrusor muscle bundles. So what about the prognosis of bladder neck involvement?
Paari, sorry, can we request you to wrap up, please?
Yeah. Yes, thank you. So when there is a microscopic bladder neck involvement, the prognosis, several studies have shown, is basically similar to extraprostatic extension. That is why both are staged as PT3A. The other issue is what happens when the margin at the bladder neck is involved. So this is a bit controversial. There are some studies showing that the margin, when the bladder neck margin is involved, it has a increased risk of biochemical recurrence compared to when the margin is not involved. So this is a study from Johns Hopkins, which basically shows you the 5-year risk of independent progression was 70% when the bladder neck margin was not involved versus 33% when the bladder neck margin was involved as the sole positive margin. However, a recent meta-analysis of about 22 studies done in 2025 show that this is not true, because they were able to show that the base is basically the bladder neck margin involvement. Actually, the involvement of the posterior apex and anterior margin had a higher risk of biochemical recurrence compared to the base, which is bladder neck margin or the posterolateral margin. The key thing that to note here is the length of the margin involvement, basically the 3 millimeter cutoff, and the Gleason pattern at the margin, as this particular study by Prisier and al. Showed. Those are the more important prognostic factors than where the margin is actually involved. I want to quickly go through evaluating seminal vesicle invasion. Since we are out of time, I will just mention to diagnose seminal vesicle involvement, you need two things. One is you need the wall of the seminal vesicle to be involved, and number two, it needs to be seen in the extraprostatic portion of the seminal vesicle. So this would be the extraprostatic portion of the seminal vesicle, and this would still be intraprostatic portion of the seminal vesicle when you see the seminal vesicle surrounded on three sides by the central zone of the prostate. So it has been shown that the prognosis of intraprostatic seminal vesicle is basically the same as no seminal vesicle involvement. So you want to diagnose seminal vesicle, you want to submit a section that is completely from the extraprostatic portion of the seminal vesicle, and if the cancer is involving this part, you want to call it positive. So that's intraprostatic seminal vesicle contiguous with the prostate, that's extraprostatic. And this is extraprostatic extension into the seminal vesicle wall in an appropriately submitted section. And this would be a section that was called seminal vesicle, but it's an inappropriate section because, as you can see, this is prostate, that's seminal vesicle, and that's cancer over here. This should not be staged as PT3B. And it has been shown that the mechanism of seminal vesicle invasion, whether it comes from the outside or from the inside, has no prognostic effect. And then there is some controversy as to whether bilateral versus unilateral seminal vesicle has better prognosis or not. Recent studies have shown a correlation that bilateral seminal vesicle invasion has poorer prognosis or increased chance or lesser chances of progression-free survival compared to unilateral seminal vesicle invasion. So I will skip this part in the interest of time, and thank you very much for your attention.
Thank you so much, Paari. Sorry for not having enough time for you. I wish we could listen more to your insights. Now we move on to our third speaker. Is a special guest, Dr. Udit Singhal, who is a board-certified urologic oncologist who specializes in the management of patients with kidney, prostate, bladder, testis, upper tract urothelial, and penile cancers. He completed his residency training in urology at the University of Michigan in Ann Arbor, and his research fellowship training in translational science in the University of Michigan. He then completed his clinical urological oncology fellowship at Mayo Clinic in Rochester, and he performs advanced open, endoscopic, laparoscopic, and robotic surgery. Dr. Singhal's research interest includes in development and implementation of novel precision-based diagnostics and therapeutics in all GU malignancies. He has a special interest in the integration of genomics into biomarker-driven clinical trials with the goal of optimally defining the clinical application of these tests. He serves as a urology lead of the Rocco Cancer Center GU clinical research team. He has received grant funding for his research from the NIH, NCI, Prostate Cancer Foundation, Urology Care Foundation, University of Michigan, and industry partners. He has received top honors and awards for his research from societies include PCF, AACR, and ASCO. He also serves as peer reviewer for many leading academic journals and is a member of numerous professional societies, including the AUA, SUO, SWOG Cancer Research Network, SUO Clinical Trials Consortium, and ASCO. Today, Dr. Singhal will be speaking on the topic pathology staging parameters, which impact therapy and prognosis in GU malignancies. Welcome, Dr. Singhal.
Awesome. Thanks so much for the very, very kind introduction, Dr. Chen. So, my job here as a urologic oncologist at this conference is really to provide a little bit of a clinical spin on all of the pathology and how that pathology can change what we do, whether it's in the operating room or before the operating room or after the operating room for patients. And so that's the lens with I will, share this presentation. And so we'll go organ by organ. It's not going to be limited just to urothelial and prostate here, but hopefully all of urologic oncology. And so, really to outline this, we have four general questions of what we're going to talk about. The first is, where does clinical and pathologic staging actually meet, and how often do they actually disagree? So oftentimes we can have differences between the clinical staging that we perform and then the pathologic staging that you obviously all know very well. Secondly, we want to talk about the pathologic features that can change what we do in terms of management of patients. And we'll focus on 5 different features, and I'll kind of limit that to 1 per organ. Third, we want to talk about the specific thresholds that either qualify or disqualify patients for adjuvant therapy. And that's obviously based on the surgical specimen. And these are really trial entry criteria. And so in our minds, they're somewhat precise in terms of qualifying patients for adjuvant therapies. And then lastly, we want to talk about where I think kind of staging maybe falls a little bit short and how we can be forward-looking. And in my mind, what kinds of things are replacing staging or maybe augmenting staging and what we should be looking at moving forward. And I think, again, the unifying thread that kind of runs through all 4 is the question here at the bottom, which is that, what findings on a report actually change clinical management and what findings on a report don't actually impact clinical management. And so, really the first, again, is clinical stage and what we use to define clinical stage and perhaps when or when not to operate. And so obviously clinical staging is built from a combination of the physical exam, it's from the imaging that we obtain, from the biopsy that we sometimes obtain. But generally speaking, it's systematically a little bit limited. It can only see what can be picked up on imaging or what can be sampled with a needle biopsy. And often that can be heterogeneous and obviously on imaging, there's no microscopic visualization or evaluation that occurs. Pathologic staging obviously is different. It gives us different information. It helps us decide whether, for example, the patient gets adjuvant therapy. It can help define prognosis. It can help inform trial eligibility. But again, pathology is limited by what's in the specimen and what was submitted for pathologic analysis. And so that sometimes is not 100% of a specimen. Here's just a few different examples of timelines from surgery for consideration of adjuvant therapy across urologic malignancies. On the left is kidney, so adjuvant pembrolizumab and kidney cancer required randomization within 12 weeks of nephrectomy. Another trial in bladder, Checkmate 274, required surgery within 120 days. The POUT trial for upper tract required the first cycle of chemotherapy within 90 days of surgery. And in prostate, the trigger is not based on calendar, but really PSA trigger between 0.1 and 0.2. And we'll kind of talk about all of these. But the point here is that us getting the surgical pathology soon after surgery does matter for patients to help get them set up for their next step in their treatment. And so, how often is clinical staging wrong? Again, I mentioned that it's limited based on our imaging. It's limited based on our biopsy, based on, what we can see, without a microscopic analysis in a lot of cases. And so we obviously consider pathologic staging the ground truth. So I think it's important to understand how often our clinical and pathologic staging are discordant. And so if we look at this, about half of patients undergoing a cystectomy are clinically understaged, and 46%, and I would argue that's even higher in higher grade disease for upper tract tumors are understaged on uteroscopic biopsy. And a lot of that is due to the fact that we don't have great methods for biopsying patients in upper tract disease. So we use very small endoscopes with very small biopsy forceps or other biopsy instruments. We're often biopsying very small areas. And so the tissue yield of our biopsies is very, very small, and therefore that makes proper staging preoperatively or pre-surgically very challenging. 23% of biopsy grade group 2 prostate cancers are upgraded to 4+3 or worse at the time of prostatectomy. Sensitivity of CT for perinephric fat invasion and kidney cancer is only 69%. And about 30% of clinical stage 1 non-seminoma already have occult retroperitoneal disease. And so, again, clinical staging is not often very concordant with pathologic staging. The other thing that we just discussed is that bladder and upper tract get understaged because invasion is missed. Again, I mentioned in upper tract disease, this is all often due to our imperfect techniques that we have. We again use very small scopes, biopsy very small areas. We don't have good ways to get adequate tissue in that scenario. In testis cancer, testicular stage 2A often gets overstaged. Again, imaging itself cannot distinguish between viable germ cell tumor that could be present, whether it's necrosis, viable germ cell tumor, or teratoma. It's hard for us to know just based on imaging. Again, prostate gets undergraded. It's often limited by our sampling biopsy techniques. We can't sample the entire prostate prior to surgery, and therefore our biopsy techniques are really just taking quadrant-based specimens from the prostate overall. And so really the argument for the whole talk is that if clinical and pathologic stage did agree, we wouldn't have to wait for the pathologic specimen to decide what to do next. And so it's really important for us to improve our clinical staging techniques, but then we really do rely on the pathology from the surgical specimen to really make therapeutic decisions. And so I want to kind of highlight how pathology can change what we actually do in clinical practice. And so this is, again, 5 pathologic features that change what we do, and we'll limit it to 1 per organ. And so we'll start with prostate. And I think one thing that can happen quite commonly in prostate cancer is that you can have a positive surgical margin after prostatectomy. And intraoperatively, from a surgical standpoint, we really don't have a sense of where tumor starts and stops, right? In the operating room, even with robotic, surgery, we're not able to see where tumor starts and stops. And the most common sites of positive surgical margins are at the apex and at the posterior lateral surface where the neurovascular bundles are, and where we're kind of attempting, for quality of life outcomes to spare nerves for patients. And therefore, we're getting quite close to the prostate capsule oftentimes to try to spare those neurovascular bundles. And therefore, we're dissecting closer to the prostate. And so, it's not necessarily extra prosthetic extension, this positive surgical margin. It doesn't change the T stage, and margin status is not included in the AJCC staging at all, but it does provide us with information, and it does change what sometimes we do for patients. But if you look at kind of how patients behave based on their margin status, you can see what it does here. So if we evaluate the 5-year freedom from biochemical recurrence, you'll see that it's 96% for patients with T2 organ-confined disease with negative margins, and then 82% for patients with organ-confined disease with a positive margin. which is almost similar to the 78% for patients with T3A disease who have negative margins. So a positive margin in T2 disease kind of behaves or looks like a T3A with clear margins. And so, what I actually use from the report is I would say 3 different things if we were to see a positive margin. I want to know where the margin is, how long that margin is, and then ideally, if we could know the grade at the margin. So the grade at the margin moves biochemical recurrence risk from 36% in patients who have that grade group 1 or Gleason 6 disease to 82%, in patients that have higher risk grade groups. And so the stage code on itself doesn't give us really any of that. And so that's all important information that we would love to see. And so next, why does that matter? So when patients see a positive margin, they can sometimes panic. And so what does that actually mean in terms of long-term outcomes? And so if you look at the literature in this study, over 9,000 organ-confined prostatectomies were looked at. The 6-year recurrence-free survival was 89% with a negative margin and 88.4% with a margin under 3 millimeters. So a positive margin does not always mean worse outcome or destined for recurrence. So it's essentially the same there. Only 3 millimeters or more stayed independent on a multivariable analysis. And so the length of the margin does actually matter. And in many cases, if a patient has a positive surgical margin less than 3 millimeters, I'd almost rather not see it on the report as a surgeon because it causes quite a bit of patient anxiety and significant conversations, but it really doesn't change what we do clinically and doesn't change the patient's outcome long term. So if we look at another study, this study looked at over 3,700 patients with PT3 disease, 8 years of follow-up, no adjuvant therapy or radiation given here, and a margin of 4 millimeters or more clearly here worsened biochemical recurrence at 45 versus 28%. But again, metastasis-free survival and cancer-specific survival are the same. And so even if you have a larger positive surgical margin of 4 millimeters or higher, that may increase your risk of biochemical recurrence, but it really does not change the risk of metastasis or the risk of dying from prostate cancer. And so that's what I tell patients, is that you may have a small increase in the chance that your PSA may come back at some point, but really in terms of a measurable increase in the chance of dying from the disease, that really has not been shown in the literature. And so your the ISUB and EAU guidelines both require reporting the margin extent, but really no treatment guidelines actually use it to guide treatment. And so if we go to bladder, what about bladder? There's kind of 3 different things that we look at. So if the report shows muscularis mucosa invasion, which I know was mentioned earlier, it's really just lamina propria invasion. And I think as practitioners, as urologic oncologists, sometimes our trainees or those who may be less experienced may see muscularis mucosa invasion and label that as higher risk disease when in fact that's just T1, lamina propria invasion. It can confuse people because that's not muscularis propria invasion, which is T2, which is really the trigger for more aggressive treatment with neoadjuvant perioperative systemic therapy and radical cystectomy. But almost 30% of those patients with muscularis mucosa lamina propria invasion turn out to have muscle invasive disease on restaging. Then this is something that I've seen a few times is smooth muscle of indeterminate type. And if it says that indeterminate type, that's about 52% of those patients, and the median survival is 30 months, which kind of tracks like the muscle invasive curve, not the T1 curve. But if it's not called muscle invasive, that patient is, in my practice, going back to the OR for a repeat transurethral resection. So if we're not seeing a definitive muscle invasive diagnosis on the pathology, if we see something like smooth muscle of indeterminate type, to me, that's not good enough to call that T2. I have to take that patient back to the OR for transurethral resection and repeat sampling. And then if muscle is just simply not in the specimen, so muscularis propria is absent, 61% turn out to have muscle invasive disease versus 40% when it is present. And so we do need to go back and get that muscle to adequately stage the patient, after TURBT. So if I do a TURBT and that patient does not have muscle in the specimen, I really do want to take them back, and they have high-grade disease. I really do want to take them back to the operating room to do a repeat resection TURBT. And so, really in our case, why we generally rather read muscular propria as not identified than a hedge. And so that plain statement, it's actually very helpful for us. We know exactly what to do in that scenario. When we know that there's no muscular propria identified, we have to take that patient back to the operating room for a repeat resection. Another thing that comes up in bladder, and this is something that was already touched upon, that tumor can reach the prostatic stroma in two ways. One route is transmural, which was again discussed, contiguous spread, where the bladder tumor grows through the full thickness of the wall and into the stroma. And again, that's T4. And then the other is the intraurethral route, which is non-contiguous, and that's T2. And the second route obviously does not upstage the patient to T4 disease, and the outcome difference isn't subtle here. Again, it was touched on previously, but the median cancer-specific survival is 16 months for someone who has transmural spread versus not reach for intraurethral. And the node positivity rate is much higher in those patients with T4 compared to that T2 route. And practically speaking, these are very different conversations in the clinic. And T4 disease, we are definitely or likely to counsel the patient for the need for adjuvant therapy and much closer surveillance, whereas in PT2, that may not be the case, especially as we start to utilize or leverage MRD assays for determining need for adjuvant treatment in the future. In kidney cancer, I would say 30% of tumors that look organ confined turned out to have renal sinus fat invasion when the entire tumor sinus interface is embedded. And 28% get upstaged from T1 or T2 to T3 based on what was a prospective protocol-driven sinus evaluation. So sinus invasion can be present when it's not initially seen. And really, grade matters as well. 71% of grade 3 to 4 tumors invade the sinus versus 17% of grade 1 and 2 tumors, with no tumor invading the capsule without also invading the sinus. And so why do we care so much about sinus invasion? Because it really helps us understand what T3 disease is. And T1 to T2 without grade 4 sarcomatoid change does not qualify someone for adjuvant therapy. And this is based on the Keynote 564 adjuvant clear cell RCC clinical trial, which in which adjuvant pembrolizumab showed an overall survival benefit. So really, we do want to know who has T3 disease and who does not. PT3 of any grade does qualify that patient for adjuvant therapy. And again, that's an overall survival benefit that's been demonstrated now. And so it's an important distinction for us therapeutically. And it's not obviously something that we can call in the operating room. So again, as I mentioned previously, CT scans miss perinephric fat invasion with a mediocre to low sensitivity of 69%. And this is a variable in kidney cancer that we're completely dependent on the specimen. This is not even something I can see in the operating room in most cases. So, when we're doing a radical nephrectomy, even robotically, we're not able to assess for microscopic, obviously, fat invasion or sinus invasion in most cases. In testis cancer, the spermatic cord, so continuous extension is T3, but a tumor confined to the cord lymphovascular spaces is T2, but a discontinuous deposit, which we don't see often, but we can, is actually staged differently, and that would be M1. And that forces kind of the prognostic stage 3, and in practice, chemotherapy is what would be given in that for a young man, and so that's a big distinction. And then secondly, the key one in testis cancer, obviously, as you all know, is lymphovascular invasion. The relapse on surveillance for clinical stage 1 non-seminoma is about 40% or higher. I would say, depending on the additional pathologic factors, probably much higher than that with LVI versus about 17% without LVI. And chemotherapy or surgery or other adjuvant approaches can reduce that risk, but those things really are offered to patients with lymphovascular invasion, and usually not for patients with stage 1 non-seminoma in the absence of lymphovascular invasion. And an interesting thing that I noted was that the inter-observer kappa for the presence or absence of lymphovascular invasion from a pathologist is about 0.5. And so, I found that quite interesting because, from a pathology standpoint, the agreement between pathologists can be so variable, but the presence or absence of LVI for us, from a clinician standpoint, really makes a big difference as to how we treat that patient. So now I want to kind of get into some of the adjuvant cutoffs and the specific thresholds that we utilize for adjuvant therapy, organ by organ. And again, these are trial criteria, so it is somewhat precise for us because we kind of try to apply the same criteria that were used in the big clinical trials to our surgical specimens when we receive these pathology reports. And so for prostate, there's 3 big randomized controlled trials that asked whether adjuvant radiation beats early salvage therapy in the post-prostatectomy setting. I would say it's worth stating that these trials did not share a definition of high risk. They all had different definitions. And so I've outlined some of those definitions here. The Radicals RT trial accepted a pre-op PSA of 10 on its own, where others required kind of both stage and positive margins. And the answer from these trials was that adjuvant radiation therapy in the post-prostatectomy setting is equivalent to early salvage therapy. And there was a big meta-analysis called the artistic meta-analysis that was done that showed an event-free survival hazard ratio of 0.95. And if you look at the Radicals data at 10 years, the distant metastasis rate was 93% versus 90% metastasis-free survival rate. And roughly 50% of the patients who received early salvage never actually needed in that arm never needed radiation at all. And so currently in practice, based on the AUA and ASTRO guidelines, there's a strong recommendation against routine use of adjuvant radiation. And so we generally will wait for PSA thresholds for biochemical recurrence and then trigger patients for early salvage therapy rather than adjuvant radiation therapy. Sometimes an exception to that can be in patients with pathologic node-positive disease, and patients with 2 or fewer positive nodes in Gleason 7 to 10 and either T3B or T4 or a positive margin. There are some studies that have shown that adjuvant radiation plus ADT gives a cancer-specific mortality hazard ratio of 0.3. But again, retrospective and in practice, I would say, generally speaking, we do wait for PSA triggers to then trigger patients to early salvage therapy by generally a PSA of 0.5, hopefully sooner than that, but generally by PSA of 0.5 for early salvage. One other thing that I'll mention, because this is new from this year, Proteus, which was a neoadjuvant adjuvant ADT and apalutamide study in patients with high-risk localized prostate cancer. They actually put a pathologic co-primary endpoint into the phase 3 trial. And it showed that those who received ADT and apalutamide had less adverse pathologic features compared to those who were on ADT alone. So, we may, as pathologists, you may see more patients getting neoadjuvant ADT, prior to their prostatectomy, and then now have to look at those specimens and treated samples. And so that'll be a new and unique thing that may be coming down over the next few years in practice. In bladder, things are a little different. So every adjuvant trial in muscle-invasive bladder cancer used kind of the same criteria. And historically, before the advent of enfortumab vedotin and pembrolizumab, which is something that we'll talk about, this was kind of used after neoadjuvant chemotherapy. And so patients who had neoadjuvant chemotherapy that were YPT2 or above, or anyone who had kind of node-positive disease would get adjuvant therapy. In those patients who were neoadjuvant chemotherapy naive, that threshold or cutoff was T3 disease or higher or node positivity. Checkmate 274 was a trial that looked at adjuvant nivolumab, and this gave a disease-free survival benefit with a hazard ratio of 0.74. Another trial was Ambassador. This looked at adjuvant pembrolizumab, again, in urothelial cancer. The co-primary overall survival endpoint was not met for this. IMvigor 010, this is another a trial that looked at adjuvant atezolizumab. The trial itself was negative, but its ctDNA analysis led directly to IMvigor 011, which we'll talk about in a little bit. And an adjuvant cisplatin-based chemotherapy overall survival had a hazard ratio of 0.82. And so that kind of equates to about a 6% absolute gain at 5 years. I would say 1 point on node count, node density, extranodal extension, those things are all prognostic, but none of them affect eligibility. None of them really change what we do in terms of therapeutic decisions. And so every one of these trials just really treats the presence or absence of node positive disease. It's just a binary outcome, and that's how we use it in practice. If we look at upper tract, one of the things that we have historically used is the POUT trial, and that's been the trigger for the use of adjuvant chemotherapy after nephroureterectomy in higher risk upper tract patients. And so these are patients with T2 or T4 or any nodal status that was positive that received 4 cycles of adjuvant platinum-based chemotherapy after nephroureterectomy. And the 5-year disease-free survival for patients that received that therapy on POUT was 62% versus 45%. And this held for actually carboplatin as well as cisplatin. But interestingly, we talked a little bit about Checkmate 274 that looked at adjuvant nivolumab. There was 150-ish patients out of 700 patients on that study that were upper tract patients. And actually, the disease-free survival hazard ratio benefit was not seen with nivolumab in the upper tract population in this trial. And so that was interesting. And so, in some cases, if a clinician, saw that, we would often not use adjuvant IO in the upper tract setting. The other thing that, I want to mention is that there's a problem with, PT3 disease or the staging in upper tract. The AJCC defines it as invasion into peripelvic fat or renal parenchyma. And in some ways, I'd argue that these are kind of 2 biologically different events in one category because there's a roughly 3-fold difference in prognosis between them. And POUT kind of treats all of those the same because those patients are all PT3. One of the things, again, that I'll want to emphasize is that uteroscopic biopsy is reliable when it's positive, but it's unreliable when it's negative. Its negative predictive value is 60%, and its positive predictive value is 94%. And so that's kind of the rationale for giving patients adjuvant chemotherapy after nephroureterectomy, because POUT enrolls patients, mainly all on the surgical specimen and not the biopsy, because we really want to reserve the chemotherapy or the additional systemic therapy for those patients who are the most high risk that really, really need it. But all of that kind of changed now with EV Pembro, which I'm sure everyone here has heard about. So EV 302 really was the big trial that established EV and Pembro as first line in locally advanced or advanced disease. And so this showed that 27% of those 886 patients that had an upper tract primary did just as well in the subgroup analysis as everyone else, and with an overall survival hazard ratio of 0.54. And so the FDA indication really doesn't have any sort of qualifier based on upper tract versus bladder disease. This is equally used now for both patients with bladder and upper tract disease. And the EAU guidelines actually give it a strong first-line recommendation inside the upper tract guideline itself. And then you had the perioperative trials. So these are EV 303 and EV 304. And this is in cisplatin ineligible and eligible patients that received EV Pembro, both neoadjuvantly and adjuvantly. But these trials did actually not enroll patients with upper tract cancer. So this is just bladder cancer only. But what we do now in practice is that we kind of extrapolate the EV302 data, and we generally do use an EV Pembro perioperatively for patients with higher risk upper tract disease. There is a perioperative trial for upper tract urothelial cancer that's kind of ongoing for EV Pembro, and that's phase 2, including being run here at Michigan, called the Neptune trial, which many of you may be familiar with. For kidney cancer, again, keynote eligibility is based on the pathology report. We kind of mentioned this. I can't make this clinical assessment based on imaging or based on visualization in the operating room. And so, again, intermediate risk, intermediate or high risk is T2 with grade 4 or sarcomatoid, or T3 or higher. And then high risk is T4, anybody with node positive disease, and then M1 with no evidence of disease after metastasectomy. And so these are the patients that are qualified then for adjuvant pembrolizumab, which again showed an overall survival benefit for patients with clear cell renal cell carcinoma. And then new, kind of recently published this summer, this is the LightSpark 022 trial that showed adjuvant pembro plus belzutifan showed a disease-free survival benefit. The overall survival benefit is still pending, so it's kind of variably used in practice still. I wouldn't say that it's blanketly applied, just because the benefit of LightSpark 022 thus far really just a disease-free survival benefit. And there was significant toxicity at 52% versus 30%. And so not every patient with PT3 or higher clear cell RCC is getting belzutifan in addition to pembrolizumab quite yet. And then, really everything else is negative, as I mentioned, in RCC, in terms of adjuvant benefit for IO. And so it really does matter. It is important for us to know T3 disease and higher and to be able to qualify these patients for adjuvant therapy. As far as testis, so clinical stage 1 seminoma, the NCCN now discourages risk-adapted management altogether and recommends surveillance for essentially anyone who will be adherent to surveillance. And this is definitely how I practice. So all my patients with stage 1 seminoma get surveillance only with no adjuvant options. The EAU still records size over 4 centimeters and re-invasion. But again, all patients with stage 1 seminoma, they get surveillance. In non-seminoma, the LVI is really the decision variable. So the presence or absence of LVI can make a big difference. And so let's say if a patient has LVI and has over 50% embryonal component of their non-seminoma, their risk of relapse is over 50%. It's probably around 55 or even 60%. And so those patients can get risk-adapted therapies and offered primary RPLND or chemotherapy in that setting. Whereas someone who is maybe absent of LVI, that patient would undergo surveillance for sure. In after chemotherapy at the time of RPLND, we often will see about 45% of these patients having necrosis, 40% having teratoma, and maybe around 10% with viable germ cell tumor. If viable germ cell tumor is present, the 2001 international series showed 2 more cycles cuts relapse rate, but didn't improve survival. And a 2023 multi-institutional series found it didn't really reliably do either once you control for the risk group and percent viable tumor. So what predicts outcome is, I think, the report itself. So it is important for us to know what's on the report. So one, it's complete resection. We want to know how much percent viable germ cell tumor there is. So if it's less than 10%, that's important information for us because that helps give us a good prognostic assessment for that patient. And again, we may not necessarily give that patient adjuvant chemotherapy, which is usually 2 cycles, but there can be some instances where we may consider it. But understanding and knowing that viable germ cell tumor fraction is less than 10% is important. So again, from a pathology standpoint, the 2 numbers we look for are the percentage of viable tumor in the RPLND specimen, and then the percent embryonal component in the orchiectomy, which can be a risk factor for relapse. In penile cancer, first T1A versus T1B, the presence of lymphovascular invasion, perineural invasion, high-grade disease, Any one of the three makes it T1B, and T1B is what kind of sends a clinically node-negative man to inguinal staging. And second, the change from the 7th to the 8th edition, the spongiosum was previously T2, is T2, cavernosum is T3. In the 7th edition, both the corpora were T2 and urethral invasion was defined as T3. And I think that can still sometimes be confusing to people. Third is kind of the nodal categories. So N3, extranodal extension of any node, or pelvic nodes, that can kind of jump to N categories for a given patient. And then the other important aspect of this is that P16 should be assessed. The EAU and ASCO guidelines make that a strong recommendation, and HPV-associated disease generally does better in penile cancer, but unlike the oropharynx, it doesn't determine stage. And the adjuvant chemotherapy decision for PN2 versus N3 kind of rests on weak recommendations at this point. There is a large clinical trial still enrolling IMPACT in penile cancer with anticipated completion in 2027, which will help us answer that question a little bit better. And so just to kind of get towards the wrapping up here, this is kind of the slide summary of all the adjuvant thresholds across the different urologic malignancies. Every threshold in this table comes from the surgical pathology specimen. It's, again, not from clinical staging, not from the imaging, not from the biopsy. So it is important for us to have accurate pathologic staging. And so the last kind of section here is where I think staging needs to go. And I'll be clear that this part is generally my opinion. So this is not backed necessarily by data, but of course, where I think that we may go in the future. So we talked a little bit about why T3 is important in RCC, but T3A bundles 4 different kind of events into one category. And so you can see that the 5-year disease-free survival by site of invasion is different. So if you have sinus fat invasion, that's 76%, perinephric fat invasion, 68%, renal vein invasion, 64%, and vein plus fat, 50%. All those are T3, but that T3 category in terms of at least 5-year disease-free survival is very different. And so T3 can be heterogeneous, and all of that gets bundled into one. Upper tract T3 kind of does the same thing. So peripelvic fat or cortical invasion carries a 3-fold worse prognosis than medulla-only invasion, and they kind of get the same adjuvant recommendations based on T3 disease at this point. The opposite really happens in bladder cancer. So T3A versus T3B, there's really identical 5-year survival between those groups, and nothing about that distinction changes what we do in practice. And so really, to me, a T3A versus T3B really doesn't make a difference. And so we have subcategories that don't discriminate. We have some single categories that are hiding kind of 3-fold differences. Prostate kind of fixed this already. As was mentioned previously, there's no T2A, B, and C. That was kind of abolished in the AJCC 8th edition for exactly this reason. And so what's kind of replacing that? There's 3 things that have kind of changed in the last 18 months or so, and selection is somewhat moving back to clinical stage in urothelial bladder cancer. In bladder, Niagara gave adjuvant durvalumab to basically everyone enrolled on clinical stage T2 to T4A, regardless of what the cystectomy specimen showed. And then, as I mentioned, EV303 and 304 do the same thing. And so MRD, or minimum residual disease, molecular residual disease, is now kind of becoming more in play. And so you have the IMvigor011 trial, which looked at adjuvant atezolizumab, and that initial study was negative, as I mentioned, but their subsequent analysis of the ctDNA positive patients show that those patients are the ones that got a disease-free survival benefit and an overall survival benefit. And patients who stayed ctDNA negative, again, in the adjuvant setting, had 88% 2-year disease-free survival with no treatment. And so, there's some data now here to suggest that using these MRD assays or ctDNA assessment can help guide who may or may not benefit from adjuvant therapy. And so that's not necessarily the pathologic specimen at all, but that's just a blood-based analysis. And then, as we kind of start giving more upfront systemic therapy, the pathologic specimen's job is kind of shifting from selecting patients for adjuvant therapy to measuring response of disease. And so, in patients, pathologic complete response went from 27 to 37% with durvalumab, and then from 9% to almost 60% with EV pembro now. And then, as I mentioned, even Proteus uses kind of a pathologic response endpoint in treated tissue. So you'll start seeing more prostatectomy samples now that are pre-treated with ADT or apalutamide. And that's something that pathologists will have to get used to. But I would say the report is not becoming less important. It's just being different questions being asked from the report now. For 30 years, it was kind of how far has the tumor spread? Can this patient qualify for adjuvant therapy? Now it's what's left after treatment. Now it's kind of we're measuring a response to an initial systemic option. And so here's where kind of I think we should put effort as a group, as a field moving forward. I think, again, these are my own views. I offer them as a clinician, as a practicing urologic oncologist, and so take it with a little bit of a grain of salt. But one, I would split the categories that group unequal patients and remove the ones that don't discriminate outcomes. So kidney T3A and upper tract T3 need kind of some more subdivisions. And then bladder T3A and T3B doesn't really need to exist. Two, I think it's important to make the descriptors that actually drive therapy required. So cribriform architecture, intraductal carcinoma, and prostate cancer make a difference. Margin length and margin grade, like I mentioned, the data that I showed, that makes a difference. Percent subtype, histology, and testis cancer can make a difference. Three, we need to standardize the sampling and not just the reporting, and that's kind of on our end. First, I think it's important, at least in kidney cancer, for example, to assess the tumor sinus interface, because again, that can make a difference. As was discussed previously, the bladder neck sections that let you trace the route of prostatic stromal invasion, that can make a difference. I think it's important to build reproducibility into the definition. So, again, that was surprising to me to see the kappa for pathologist variability between LVI determination and testis cancer was only 0.5. And then I think we need to plan for staging that's anatomic and molecular. And so ctDNA, like I mentioned, is already now becoming a selection criteria in bladder cancer for adjuvant therapy. It could be interesting to incorporate this with pathologic staging, and that could be helpful moving forward. And so the final takeaways, that I hope that everyone takes from this is that the AJCC 8th edition still governs really every GU site, but what those categories are being used for has kind of changed over time. Clinical staging, again, is wrong often. It can be wrong often. It's limited by what we can see. And it can often be in a predictable direction. About half of those patients in bladder cancer can be understaged, definitely in upper tract disease, also seen in prostate cancer. There's things that can change management more than the T stage itself. It's what wasn't sampled or the heterogeneity that may exist, the margin status, the lymphovascular invasion presence or absence of this. And then where categories are prognostically heterogeneous, like renal T3A and upper tract T3, we're kind of treating unequal patients all the same because they're all in the same category. So having a little bit of increased discrimination here would be important in my mind. And then the last one, just one plug I want to put in is I hope that as a pathologist that everyone feels comfortable in calling us, if there's a finding that you're seeing under the microscope that you think might change stage or change therapy or is not making sense. We're always, as urologic oncologists, as urologists, as surgeons, happy to take a phone call, happy to talk through it. And I always appreciate when the pathologist gives me a phone call. Dr. Mero does that often, and I appreciate that because it helps have a good conversation that can ultimately change management decision-making for patients. And so I think it's quite important to work as a team and approach it in a multidisciplinary manner. So thanks so much. Happy to take any questions.
Thank you, Dr. Singhal. Amazing talk. I really enjoy it. So I think, we're running over time and we have a few minutes for just a couple of questions. And I'll just get started by directing one question to Dr. Choy. about bladder cancer. So one of the most important challenges, the differentiation between muscularis mucosa and muscularis propria in TURBT specimens. So sometimes people try Desmin and sometimes it's not helpful. So what is your suggestion in particular with a large urothelial carcinoma that maybe sometimes urologist has mentioned that muscularis propria has been sampled? What's your approach for that?
It's certainly a very common challenge that we face when we have our TURBT specimens, and we're really wanting to make sure to note whether or not is muscularis propria present, because that is a quality, an adequacy surrogate for the specimen. So, sometimes stains, the mentioned Desmond, doesn't really differentiate between the two, muscular mucosa or muscularis propria. Smooth one, people have shown that potentially the intensity of the stains could differentiate the two. It is not recommended routinely to be used for any of these IHC. And for myself, if I do use it, it's on a rare occasion where I'm really trying to prove one way or another. Otherwise, I truly do default to how my mentors have taught me. It's going back to the HNE, going back to the morphology, and really trying to assess if there's any clues, whether or not, depending on the location of the tumor, and our understanding of that variability of the changes and how the different layers are present in those particular areas, and really see if we can use just what is on the slide to make that diagnosis. Of course, on the rarest occasion, as much as we want to be perfect and provide a very definitive diagnosis of whether or not is there muscularis propria there, muscularis mucosa versus muscularis propria. As pathologists, I think we all strive to try to be very definitive, but there will be times when you just cannot. And I think there is something to be said about that too, of really, in those cases, communicate with your urologist and have that discussion of saying, we try our best, we try every method. There is just not a definitive one way or another, whether or not muscularis propria is present or not in this sample. And usually that communication is really worthwhile having to determine kind of what's next for this patient, because we don't want to also just assume one way or another, because it might change the direction of treatment, whether or not the patient is brought back for a re-TURBT for certain specimens or not.
Thank you. I think we have.
Sorry, Jeff, I see your message. So there's a question for Dr. Singhal. For neoadjuvant nephrectomies, what elements in the pathology report are clinically relevant? Percent viable tumor, is there a cutoff? Would you need to submit the entire tumor bed, or would you like that submitted for review?
Yeah, it's a good question. So right now in clear cell RCC, at least, we don't necessarily, and all across kidney cancer, we don't necessarily have, thresholds that have been validated for percent viable tumor and their correlation with outcomes. But I will say that Dr. Mehra, for example, has been involved in helping establish those thresholds and has published previously on this. And there's additional investigations that are upcoming that will hopefully help establish an adequate threshold for percent viable tumor in kidney cancer that then correlates with outcomes. And so, as the other thing is, as we do more neoadjuvant treatments and do neoadjuvant trials, we'll then have the opportunity, based on surgical pathology, to assess those surgical specimens that have been pre-treated, and then correlate that with long-term outcomes. So in kidney cancer, to answer the question, that threshold is not known yet. It hasn't been validated or assessed and known, but there is ongoing work to help establish that moving forward as we see more IO used preoperatively.
Thank you, Udit. And maybe the last question I have, and perhaps Paari can address it, and I'll be curious what Udit also thinks on this, is the studies which have looked at focal versus established extraprostatic extension, and Paari had shown like really some nice images, how a few glands or a limited high power field. Most of the studies were done like a while back. And I'm just curious, and I would like to hear from or learn from both Paari and Udit that do we feel that we need a new study in this space, or are we like practically handling these cases different from a clinical level? And so I'm curious, like, what is the update on this? If Paari and Udit can please share.
I can say from a clinical standpoint, at least from a management paradigm standpoint, whether the patient has focal extraprostatic extension or established extraprostatic extension would not change how we manage the patient, especially with the trials that I shared, the adjuvant trials that showed no benefit of adjuvant therapy versus early salvage. So PSA trigger is still the bottom line in current practice. And so whether that's established or focal, we as practicing oncologists are still going to wait for that patient's PSA to show a rise before we trigger them to any sort of therapy after surgery.
All right. Yeah. Thank you for sharing that, Udit, because I still see pathologists actually trying really hard or sometimes struggling to figure out, and even the criteria are not very clear between focal and established. So I think that is helpful. I believe Paari had to move on to another meeting. If everyone is okay on our forum today, Emily, Udit, Bonnie, and Jeff, and I think, is it okay to close this session, please, now?
Absolutely. Thanks for inviting me. Appreciate it.
All right. Right. Yeah. Thank you very much. I think before we close, again, I want to express my sincere appreciation to our speakers, Dr. Choy, Dr. Murugan, Dr. Singhal, for your time, expertise, amazing presentations, just such thoughtful contributions to today's presentations. I think all of us learned so much, and I think, and of course, having an eminent clinician like Udit, I think that was just like amazing. We don't get to hear every day the clinical side of the story, right? So I think I know that all of us learned a lot today. I'm also thankful to Jeff and Emily, our session co-organizers and moderators. I also loved actually how each of our speakers today, as well as in our previous session, Barak, Ankur, as well as Stephanie, and today's speakers also had also emphasized on what is pending in terms of improving our staging parameters. And I think also like how today's speakers, and including Udit, how they essentially showed us that we need to evolve in our thinking about staging, where we might even have to incorporate some clinical and molecular parameters. All right, with that, I think, sorry we went a little bit overboard today, but I think in terms of time, but I feel, I think it was like an amazing session, and I at least learned a lot, and I hope everyone did as well. Thanks to everyone who joined us today. I know it is very late in some parts of the world, and we do look forward to continuing these important conversations in future GUPS events. Thank you, and bye for now. Take care, please.
Thanks, y'all.
Thank you.